make their final decision. One more thing is the protection of health. So the patient's health safety is very important and should be protected. So the providers have obligated to always play it safely with the patients and the follow-up care on the patients. And definitely the confidentiality, just like any other procedure. Blood transfusion, blood products transfusion also has to be dealt with it. It was full confidential. So why we're saying this? Somebody can ask this question. I mean, I thought like transfusion is very simple and very easy. Can transfusion cause harm? Yes, absolutely. A lot of us know these, and there is a long list of transfusion reactions, some which we know, some which we are not sure about, and some which we don't know even. And Dr. Blumberg yesterday, he did talk about some papers showing that lymphoma or leukemia could happen way after transfusion in many years. And that's one of my projects actually I'm working on right now. So what the big deal with cancer patients? Why we are talking about cancer patients in particular? Because cancer patients, according to multiple studies, could reach up to 60% of the anemia. Up to 60% of them have iron deficiency anemia. And that's due to multiple reasons. Could be the nutritional, as the intake, iron deficiency, vitamin deficiency, you name it. Could be due to blood loss. A lot of issues could cause the blood loss, from bleeding to coagulopathy, which a lot of people, they don't pay attention to it sometimes, and chemotherapy, excessive phlebotomy, hemolysis, which could be either oral hemolysis, mechanical hemolysis, or drug or transfusion-induced hemolysis, plus all the other comorbidities, and don't forget TREM, that could also happening because of transfusion. In this study, Hiller et al. Did a systemic search for something. Sometimes we think like it's very minor and we don't pay attention to it. But in this systemic search, they looked at the daily blood volume loss from each patient for diagnostic stuff. And they found almost 2,200 studies. 38 of them were included in their study, and 9 of them were interventional studies versus 29 of them were observational studies. And they noticed that up to 377 ml of blood could be wasted just from phlebotomy blood draw. For those who are not familiar very much with the blood banking or the size of the red blood cell, a bagged red blood cell's size or volume is about 320 to 350 ml. So here we're talking about up to more than 1 unit could be lost just because of phlebotomy. Then they show these 9 studies that's included interventional studies. And as you can see here, the cardiac and the surgical patients were lost most of the blood on a daily basis up to above 300 ml. Then they show the observational studies, the 29 studies of observational studies. And as you can see, it's high on, it's like a lot of different ranges between different studies, but the highest were in the general units of the hospitals. More than even the ICUs themselves. And that's a lot. That's reaching up to 100, 120 cc. John Hopkins study, they studied the amount of blood that could be drawn for lab test or wasted as a discard in different ICUs at their hospitals. And they found that an average patient could lose up to 60 ml of blood. 60 ml, multiply this by 5-6 days, that's about 1 unit of red blood cells. So these are the anemias that we are causing by sometimes over-testing, sometimes unnecessary testing, and sometimes you do the test and you don't even see the results. So there's a lot of wasted blood and also wasted discarded tubes that should be drawn before you draw certain blood. So what? Somebody is looking from outside. They said, so what? I can transfuse these patients. We have blood and we can replace their anemia and blood loss. So I can wait until the last minute when I admit the patient to the hospital and just give them a unit of red blood cells to fix their anemia. I would respond to them. Blood transfusion does not have a very good outcome. It does not improve outcomes. We have to keep this in mind. We have to keep in mind that the allogenic blood is not the perfect substitute for the patient's own blood. There's tons of stuff happening to the blood during storage, and that's known as a storage region. That's including changes in the membrane and including the defect in delivering oxygen. In addition, you have to keep in mind that blood is an organ. It's a liquid organ. And when I do someone transfusion, it's not different from a transplant, an organ transplant. And that could cause a lot of stuff, including the TRIM and inflammatory, and plus also all the side effects we just talked about. Look at this here, electron microscopy shots of red blood cells. Even up to 12 days of storage, you start having some echonocytes in the unit. That's up to 12 days. If we get the unit with about 5 to 7 days to the hospital, so about several days after that, the unit has started having a lot of abnormal red blood cells, which is less elastic and less capable of moving in the capillary vessels. Wait until the end of the storage, about 40 days or so, you barely can see any normal cell in this the storage red blood cells. Not only this, we know that during storage we have a decreased 2,3-DPG, which cause high affinity to oxygen. What mean high affinity to oxygen? That means the red blood cells is going to bind to the oxygen and not leave it. It's not going to give it to the tissues. And this is very well known. And a lot of studies, they said, oh yeah, but once you transfuse, these red blood cells will regain this enzyme within several hours and then deliver the oxygen. We did a study to show that that does not happen. I think I gave this talk about a couple of years ago at the BMSS. And we did show that when we studied the changes in the SpO2, the peripheral capillary oxygen saturation, before and after the red blood cell transfusions, and we followed this for 24 hours. So this is where the transfusions happen and up to 24 hours. Yes, we did improve hemoglobin, which everybody is very happy about improving hemoglobin. I transfused the patients around 7, and now he's 8. I'm happy about this, but look at the SpO2. Even up to 24 hours, it did not improve. And that's taken from almost 70 patients. And we only included patients has no bleeding, no any procedures done, just regular patients waiting in the units, and just by fixing their hemoglobin. The goal was to fix hemoglobin. That's why our numbers are very low. And you can see the effect of on the SpO2. That means the oxygen is not delivered to the tissue. The SpO2 measuring the end oxygenation of the tissue, and it's not delivered here. Okay. Not only this, the PaO2 also. I forget to tell you over here. One of the reviewers said, "So what? The changes are not significant in the SpO2. I mean, it's, if you can look at this, 97 to 95, 96 is not that significant." Yes, it's not significant, but the goal for my transfusion is to improve this, not to make it less, okay? So that's really important point here. And look at the PaO2. PaO2 also reduced. And one of the reviewers said, when PaO2 reduced, that's good because that's mean no blood remained in the artery, but actually they went to the tissues. Yes, but we didn't see them in the tissue. So where are they? If they are not in the artery and they are not in the tissue, where are they? They are kept in the red blood cells. And that's what's mean the high affinity of red blood cells due to the drop in the 2,3-DPG. This data, I just got it yesterday. Last night, our statistician sent me this data. So just bear with me here because it's a little bit complicated. But what we looked at here is we measured the SpO2 before and after cell saver transfusion. So we did not include any allogenic blood here. It's auto collection of the cell saver of these patients. These patients are pediatric congenital cardiac surgical patients requiring cardiopulmonary bypass. And all of these patients are non-cyanotic heart diseases. And what she told me this, if we consider this is the time zero, this is where we gave them the cell saver product. So we checked the vitals before and after, and in this case it was SpO2. And she told me that there's a definitely increase in the lower SpO2 after the transfusion. Then we looked, I told her, I'm not understanding this, so can you send me a trend line? And that's what she told me there. She said, although it's not that significant in SpO2, but look at the PaO2. So the PaO2 also reduced here. Then we are testing another machines right now in the same study. It's called NIRS, which is near infrared spectrometry monitors, which is also measuring the oxygenation in the regional tissue and could be used as a somatic or as for the brain tissue. And for this one, we did notice that NIRS reduced after the transfusion of the cell saver product. And again, this cell saver is his own blood. The only good signs of this cell saver was in the cerebral nerves, which is measure the cerebral tissue oxygenation. And that was the only benefit, the only plus we saw in this study so far. We're still analyzing a lot of data. We're still analyzing a lot of other vitals. I'll definitely publish this data at some point. So let's get us to the point that we really need some management. We really need some patient's blood management. And that will bring us to the definition of our blood management. Everybody is aware of this definition. It's definitely to maintain the patient's own blood and avoid transfusion as much as possible. What's the difference between patient's blood management and bloodless surgery? They are similar in definitions. The only things we focus on a bloodless surgery is to optimize tissue oxygenation, to improve the tissue oxygenation in this patient's blood management. This study showing us different patient's blood management programs and different studies. And they did a meta-analysis of almost 17 studies involving close to 250,000 of surgical patients. And they found that almost 100,000 pre-patient's blood management and 135,000 post-patient blood management. And they noticed that patient's blood management definitely reduced transfusion rates by 39%. So almost 40% of the patients did not need transfusion, and that was significant comparing to these huge numbers. Almost 43% of red blood cell unit less, so close to a half unit less per patient during the study, and that was also significant. About half a day less length of stay in the hospital, and the complications were significantly different. And in addition, mortality rate was also significantly different. So there is a benefit of the patient blood management. Everybody is aware of this. And this is a meta-analysis, including 17 different studies. Now, another study by Hoffman, he focused on making the blood management the new normal. We should consider the new normal. The way he did this study, he sent questionnaires to different people who implemented this patient's blood management. And the main question was, what could be the main drivers for the patient's blood management? Why did you initiated the patient's blood management at your center? And look at the responses here. Almost more than a quarter of them, they said patient's outcome, to improve patient's outcome. Others, they talk about the cost and versus blood shortages as well, and patient safety in addition to this. So there's a lot of patients focus goals here in addition to the cost saving. Hoffman also did another study to look at what about oncology patients. He focused on cancer patients in this study. And they noticed that there's three pillars in the patient's blood management in cancer patients. First, it's not that different from our normal patient's blood management, but at least managing coagulopathy. This is very important part here. We sometimes don't pay attention to this. Why? Because there's a triad in these patients. We notice that up to 60% of them coming anemic and iron deficient. And sometimes they deliver coagulopathy or they lose blood during multiple issues, as we discussed during the hospitalization, during the treatment, nutritional, a lot of other reasons for the cancer patients not to have, not to lose blood and develop the coagulopathy, which all of this, if it's not managed very well, it will lead to transfusion. And we know about all the complications of the transfusion, as we just mentioned. So what should we do here? They suggested in this study, and they supported by a lot of different studies in that paper, is try to manage the patient's anemia way in advance. Treat anemia way in advance. Treated with IV iron, treated with ERS, and the ERS was approved for the chemotherapy-induced anemia, so that's good to use in cancer patients. I know there's a speaker who's going to talk about this after me, and they'll also talk about the iron deficiency and iron replacement in these patients, and I'm going to also leave it for the speakers after that. So the only thing about this ERS is there is a study done in 2012 which found an evidence to increase risk of thrombotic events and short-term mortality in these patients. And this makes a lot of people hesitate. And that's why the ERA right now is only approved for chemotherapy-induced anemia. Minimizing blood loss. We did talk about this. How can we minimize this blood loss? What measurements we can do? So definitely there's a lot of issues we can do here. Use the ultrasound guided vascular catheterization, fine needle biopsy, flexible endoscopy. For surgery, prevent hypothermia. Utilize topical hemostatics or cell salvage, although cell salvage in cancer patients is not preferred, but you can still use it in some cases. Point of care testing in pediatric surgical and critical ill patients, you can use this. And in extracorporeal circulation, use different methods, which we are doing it right now here, and that's part of the study we are doing here right now, is miniaturized circuits, which make the circuits less smaller and take less blood, especially in pediatric patients. And definitely use not invasive procedures to monitor blood gases. Coagulopathy. Coagulopathy, we have to make this good attention to it. First, by laboratory testing. Viscoelastic testing is very important in coagulopathy, or detecting coagulopathy or the high risk for bleeding in these patients, and start using different treatment to manage this coagulopathy, from antifibrinolytics, DDAVP, which increases factor VIII and von Willebrand factor, and also improve, and we don't know a lot of this, it's improved the binding between von Willebrand and platelet, so that's improved platelet function. That's all can be done with DDAVP dose. Cryoprecipitate and fibrinogen concentrate, very important in coagulopathy. And in addition to the vitamin K, which, by the way, up to about 4 to 6 hours, if it's IV, can fix the iron in normal liver. In non-surgical, the strength catheter immobilization, minimizing the volume blood draws, and that's also can improve the anemia and maintain patient's blood, the patient's own blood. Now focusing on improving oxygenation. So ventilation should be with 100% oxygen, and try to aim for a higher VaO2. Use high positive index respiratory pressure, sedation if needed, and keep normal thermal for the patients. All of these could help with improvement of the oxygenation. Another study done by Frank et al., and he focused on the approaches to bloodless surgery in cancer patients or oncology patients. And the question they were asking in this study, in many instances where patients cannot accept transfusion because of some religious belief or personal reasons, or sometimes in our immunization, we have a lot of patients who receive a lot of transfusions to the point that we cannot find blood for them right now. So they were wondering in their paper if these same procedures, same cancer procedures and same cancer surgeries can be done for those patients who refuse blood or cannot take blood without any drop of blood, why we cannot do this for everyone. And so they did emphasize on managing anemia way in advance. Start about several weeks before you admit the patients for the surgical procedure. And fix this anemia with either iron or with either ASA. Intra-op, they're focused on intra-op to use some meticulous surgical techniques, hemostatic agents, just like the previous paper that's they're talking about, normothermia, controlled hypertension, and also use the normothermic hemodilution. As we said, although it's controversial to use cell salvage in cancer surgery, but that could be assessed, and also liquid reduction filter may be improved the cell saver product. Post-op, full minimize phlebotomy, especially in the ICU units. Use smaller tubes if needed and less frequent to avoid the hospital-induced anemia. Another study they were done about stem cell patients, Jehovah's Witness stem cell recipient. And in this study, they found that 1 year survival between the people who went for an autologous stem cell transplant, bloodless versus non-bloodless. They found no differences, up to 88%. Were survived. A couple of cases happened due to death in this group due to different reasons, like either CNS hemorrhage or death due to sepsis. But they did not find any differences between both groups, and this is showing us here that bloodless or transfused autologous stem cell transplant show no differences in years of the outcome. And the way they focus here about the universal measures is to basically minimize phlebotomy. So we're seeing this in every single study. Every study is talking about how much blood we are using with phlebotomy. Providing vitamin K to improve coagulation factors, a lot of other in between, but I'm just highlighting the important one here. Iron for anemia. Try to seize the menses in female patients to avoid losing blood. Don't use NSAIDs or aspirin just to avoid any GI issues, and avoid antibiotic that could affect the bone marrow production, in addition to use the ASA. Anemia. So if somebody is already anemic, up to 10 grams, they said just use iron sulfate. Don't use anything else. Down to about 6 grams per deciliter, they used bed rest and oxygen, high size oxygen, up even down to 4 grams. Remember, all these patients are Jehovah's Witness patients, so they are refusing blood transfusion due to religious reasons. So that's why they are going that low, even down to 4 grams per deciliter. And in this case, it's just they suggested absolute bed rest and oxygen, a significant amount of oxygen. Now, thrombocytopenia, even not only the red blood cells, some of those Jehovah's Witness patients, they don't even take platelets. So we have also to focus on the platelets. And what they said is if you reach around 50, start with aminocarbonic acid or DTABB. And also try to cease the vaginal bleeding in a female patient, and aminocarbonic acid once you reach very low numbers. So these are like down to 10 now. Suggested aminocarbonic acid plus some other vitamin K also suggested, and topical aminocarbonic acid if you reach down to 5,000 and there's any bleeding issues. This study focused on the safety of bloodless transplantation in patients with myeloma. And this is a retrospective case control study. Included patients who receive autologous stem cell transplant, bloodless versus non-bloodless, so transfusion versus no transfusion. It was done at Emory Hospital, and they included about 24 in bloodless and 70 in transfused group. And the median progression survival was 36 months and 44 was not different between both groups. And the median overall survival was up to 59 months, and it was not different in both groups. And that's what we are showing here. These were not that significantly different up to 59 months. Again, their focus was very close to all of the other studies, erythropoietin, iron, vitamin K, tried prophylaxis of GI bleed, avoid aspirin, avoid NSAIDs, estrogen in women to avoid menstrual periods, and also folic acid to help to support with the own blood. Now, in summary, blood transfusion is not without risk. In many cases, it's better do nothing rather than intervening and potentially causing harm by blood transfusion. Keep in mind that blood is not safe. Blood procedure is just like any other procedure in the hospital. Anemia is a condition that is both treatable and preventable. So try with your patients that as long as you know that you have a procedure coming in the next few weeks, start management in the 4 to 5 weeks before that. Careful planning to how to optimize the patient's blood health and improve outcome without transfusion. The care should be minimize blood as much as needed, and every single drop counts of the patient's own blood. It's very valuable. Allogenic blood is not the perfect substitute for patients' own blood, and we have to always think about the unit that you're going to transfuse to this patient is kind of an organ transplant and could have as high risk as an organ transplant procedure. Clinical studies show that well-delivered bloodless care can result in similar or better outcomes in patients who refuse blood products compared to those who we transfuse, as we saw in multiple studies. And this is just my acknowledgement for some people who work with me in my lab or through the hospital and also from the transfusion unit. And I'll stop here. Thank you. Back to you, Victoria.
Well, thanks, Dr. Rafai, for a really wonderful talk. I think without further ado, some more, I'm going to introduce a second speaker, who is Dr. Jamila Sattar. She's going to talk about intravenous iron therapy as a standard of care in oncology. Dr. Jamila Sattar is a consultant hematologist and former head of service in hematology in Malaysia, where she is responsible for the care of patients with thalassemia, hemophilia, thrombosis, and bleeding disorders. She was instrumental to developing national thalassemia and hemophilia programs to improve the care of these patients in Malaysia. And she's also actively involved in promoting patient blood management programs to optimize patient outcomes. Just to let you all know, she's actually the pioneer, and patient blood management is actually her brainchild. Dr. Sattar is also a member of many professional societies, including the Bloodless Medicine and Surgery Society, and also International Society of Thrombosis and Hemostasis, which she managed to get of my PBM booth in this ISTH Bangkok, 22nd to 26th of June in this year. So, and she's also the former president of Malaysian Society of Patient Blood Management, which I need not to introduce more. So, Dr. Sattar, I will pass over the floor to you. Thank you.
Thank you, Mandy, for the kind introduction. And I'd like to thank Nathaniel and his team for inviting me to talk to you on the next topic, which is IV iron as standard of care in oncology. Let me see how I can put this on. Can you see my slides?
Yes.
Yeah,
Yes,
but I have to
yes.
put it. I have to put it on
Slideshow.
slideshow. Yeah, because it's hidden here. Okay. All right. Okay. Hi. Thank you, Mandy. Thank you, Nathaniel, for inviting me to speak to you. To all of you here this evening, I have no disclosures. And I'd like to say that iron deficiency is common across all disciplines and in oncology too. So we'll be focusing on oncology. And let us look at the prevalence of iron deficiency anemia in cancer or in oncology. So from the European Cancer Anemia Study, they looked at over 15,000 patients with cancer and found that iron deficiency was seen in 54% of patients at presentation. And that went up to 75% during chemotherapy. And as you know, during chemotherapy, patients, they become unwell, they may be vomiting, they can't take in well, nutrition, they can't take in good nutrition, they may have infections. So a lot of factors are involved in causing the anemia in patients who are also with cancer was also on chemotherapy. And they also found that iron deficiency anemia is 2 times more common in hematological malignancies versus solid cancers. And iron deficiency anemia in these patients can be either functional or a combination of both absolute and functional iron deficiency. Looking at another study by Ludwig, it's a study done in Austria, Vienna, Austria, looking at the prevalence of iron deficiency in the different subtypes of cancers. This involved over 1,500 patients, and they found that patients with pancreatic cancer has the highest prevalence of iron deficiency as well as iron deficiency anemia, followed by lung cancers. Hematologic cancers account for about 50% of the patients with hematologic cancers have iron deficiency. So we went on to look at our own center, Ampang Hospital, which is the National Referral Center for Hematology in Malaysia. We just looked over 3 months from July to October 2023, whereby we actually do bone marrow aspiration and biopsies for all our patients at presentation, all our patients with hematological malignancy at presentation. We had 55 bone marrow samples, of which 25 were female and 30 were male. And of these, 56% are diagnosed with leukemia, followed by 29% lymphoma and 15% multiple myeloma. So for all these bone marrows, we also do a pearl stain to look at the iron stores. So the picture on the left is absent iron stores. You see that there's no bluish coloration, which signifies iron within the bone marrow fragments, while the picture on the left shows normal iron stores. You can see the blue particles there, that's iron. So the picture on the right is normal iron stores, the picture on the left is absent iron stores. So we looked and went through all, these 55 samples and found that, actually to our surprise, 76% had low or absent iron stores. And what is more surprising is males actually had, there were 77% of males having low or absent iron stores, and compared, which is actually equivalent to the female. So I was pretty surprised because I was expecting males to have, about 30%, females about 50% absent iron stores. So only 14%, you can see on the graph on the right, had adequate iron stores. So, so 76%, having absent or low iron stores, that's a lot, to our surprise. At presentation, all our newly diagnosed hematological malignancies at presentation had low iron stores to begin with. And you imagine if you give them chemotherapy, what will happen? I think almost all will develop iron deficiency anemia, right? And in hematological malignancies, the chemotherapy is very intensive. Yeah. Yeah. So, okay. So, well, iron deficiency is common, yet it is not addressed in patients with cancer. This is a study, comparing patients who are on dialysis, receiving iron tests, and those receiving IV iron, compared to patients with cancer receiving iron tests, and those patients with cancer receiving IV iron. So the cancer patients are the one in red, while dialysis patients, kidney dialysis patients are the one in blue. And you can see the trends in iron testing and IV iron dosing is much higher in patients who are on dialysis as compared to those to patients with cancer. Hardly any patients have iron testing, and then you can see those receiving IV iron is actually going down in patients with cancer. From 1992 to 2001, the patients receiving IV iron is actually falling down. I think most of these patients are getting blood transfusion. So the myths in oncology and hematology, most of our hematology oncologists or hematology oncology doctors who are treating hematology oncology, they feel that if we give iron, the cancer cells will feed on the iron, so promoting cancer growth. And they also feel that iron increases the risk of infection and mortality. And also iron increases the risk of cancer relapse. These are all the myths that they perceive, in oncology, within the oncology and hematology fraternity. But there is no evidence to back this up. On the other hand, we have so much evidence to show that actually blood transfusion promotes cancer growth, increase the risk of infection because of the immunomodulation, and increase the risk of mortality, increase the risk of thrombosis, and increase the risk of cancer relapse. And we have heard from Dr. Neil's talk yesterday, and also from Dr. Rafai's talk, all the complications of blood transfusions in patients with cancer. So we will debunk this myths, And another thing, the hematologists are actually okay in giving the granulocyte colony stimulating factor, which you would think that it may also promote the growth of the leukemia cells, but they are just using it so freely. So why can't we be using IV iron to treat iron deficiency anemia, rather than using blood transfusion? So what are the consequences of anemia in cancer patients? It impairs organ function, it reduces quality of life, there is greater post-operative mortality, of course, greater probability of blood transfusion, following chemotherapy, and of course, a shorter survival. Okay, and what are the predictors of anemia following chemotherapy? For females, it's a low initial hemoglobin of less than 12.9. In males, it's less than 13.4, based on a study by Barrett Lee. And those with lung or gynecological cancers, those who are on treatment with platinum chemotherapy, platinum causes bone marrow suppression, and female gender. All these are predictors of anemia following chemotherapy. So why is it important to treat cancers to anemia and iron deficiency anemia in cancer patients? Because anemia in cancer has an adverse prognostic factor. It reduces survival. And of course, it's a risk factor for blood transfusion. Cancer causes cancer-related fatigue, and it reduces the tolerance to therapy. It's so important. It interferes with dosing and timely administration of treatment regimen. So you know that if you cannot give the, if the patient cannot receive a good chemotherapy regime, if they have to reduce the dose or they have to reduce the timing of the chemotherapy, that will actually reduce the risk of remission, and reduces the cure of cancer in these patients. And it also reduces, anemia also reduces motivation to continue therapy. And so most of these patients fall out, yeah? They don't come for the next chemotherapy and they're lost to follow-up. So it's so very important to treat cancer-associated anemia or iron deficiency anemia in cancer. So what does the guidelines say about the treatment and monitoring of iron deficiency in cancer patients? So I've put up the 4 guidelines here, and I picked the ASCO guidelines in 2019 saying that iron profile monitoring is recommended. Iron replacement is recommended if there's iron deficiency. Yeah. And the ESMO and EORTC guidelines also say that iron monitoring is recommended, and iron replacement in patients with iron deficiency produces increments in hemoglobin and reduces the need for transfusion. That's the ESMO guidelines. So all these guidelines recommend patients with cancer should undergo iron profile monitoring and treatment or replacement of iron if there is iron deficiency. Not just anemia, yeah? You can have iron deficiency without anemia. So a study by Noam looking at increases in hemoglobin with erythropoietin stimulating agent alone versus erythropoietin stimulating agent with IV iron. So this is actually a study to look at the various study from 2004 to 2011, showing you that if you give only erythropoietin stimulating agents alone, you wouldn't achieve the response that you want. So erythropoietin stimulating agents alone has a reduced response in hemoglobin increment, as opposed to giving IV iron. So it tells you that IV iron is needed, in treating patients, in treating anemia in cancer patients. So IV iron, is important in erythropoiesis. Erythropoiesis is the primary consumer of iron. So erythropoietin is needed in the early maturation of your red cell precursors in the early development phase, while iron is needed in the later maturation of your proerythroblast and erythroblast. So you need these two to complement each other in patients with cancer-associated anemia. But most of the time, they have both. Patients with cancer have iron, functional iron deficiency and absolute iron deficiency. So what you do is you would correct the absolute iron deficiency iron first, and then we add on erythropoietin. So IV iron. So how do I dose IV iron? So that depends on the urgency to correct deficiency. Of course, if I want to get the hemoglobin up quickly, I would give a bigger dose. If the patient's in the ward, is inpatient, and then you know that they're going to be in the ward for about 2 to 3 weeks, then I would give a lower dose as opposed to when patient is outpatient. And of course, for absolute versus functional iron deficiency, I would give a lower dose for the functional iron deficiency and a higher dose for the absolute iron deficiency. There are various iron formulations, Venofer, Cosmofer, Monofer, and Ferinjet. For the outpatients, I'd rather use, I use the higher dose, higher strength, while with inpatients, I'll use the smaller IV iron formulation strength, such as Venofer. So what I'll do is I'll share with you 2 cases. The first case is a 46-year-old lady married with 4 children. She presented with abdominal bloating for 1 month duration, and a CT scan showed a uterine mass with endometrial thickening. And this was the mass. You can see there's a uterine mass. And she she was seen by the surgeon in a hospital, and it was noted, and she was actually planned for a biopsy, for a laparotomy. Her hemoglobin was 6 at presentation, and unfortunately, she was transfused 4 packed red blood cells before the op. She developed urticarial rash with a 3rd bag and fever during the 4th bag transfusion. So she was planned for laparoscopic removal, but findings were an ovarian mass with pelvic nodes. So they proceeded with a total abdominal hysterectomy and bilateral self-involved oophorectomy and pelvic node clearance. And the HPE of the mass turned out to be Burkitt's lymphoma. Yep, and so she was referred to the hematologist, and at presentation to us, her hemoglobin was 9.3, total white 9.6, platelet 369. She was planned for 3 pairs of rituximab A block, B block, which consists of very high dose methotrexate alternating with high dose cytosine arabinocyte. So in the first 3 cycles, she was treated by a different team. She was admitted after the 4th cycle of chemotherapy under my care. She was recovering from sepsis with a hemoglobin of 6.2, and she was continued on antibiotics. Yeah, and I started her on IV iron, erythropoietin, folic acid, and vitamin B12. No blood was transfused, and she remained well and in remission until today. So this is I plot out the full blood count trend. So for the first 2 cycles of chemotherapy, there is A1, B1, A2, B2. You can look at the hemoglobin. She started off at 9.3, and then the lowest it went was 5.5. Yeah. And she had also another one at hemoglobin at 5.7. Yeah. And you can see that during this time, 900 plus 300 plus 800. 2 liters of blood was transfused in the first 2 cycles of chemotherapy alone. So she came to us, with the HB of 6.2. That's the yellow. I've put that in yellow. Yeah, the hemoglobin was 6.2 when she came to us, and Mandy and myself, we managed her. Yeah, she actually was not keen for blood transfusion. Of course, we didn't think of it. Yeah, because she was telling me if she was in the other team, she would be transfused blood, and she was not too keen because she gets reactions with the blood transfusion. So we started her. We gave her IV iron. Yeah, we gave her IV iron, and then we added on erythropoietin stimulating agent. We also put her on GCSF. And you can see when she had the last pair of chemotherapy with us, her hemoglobin ranged around 9.5, and the lowest was 8.3. Yeah, and we continued on, with IV iron and erythropoietin stimulating agent throughout her stay in the hospital and on discharge as well. And you can and when she completed chemotherapy and came on follow-up, that was a month later, her hemoglobin has gone up to 12.3, but she still remained iron deficient, and we continue on with oral iron. So the lessons learned from the first case is that, before chemotherapy, we should screen for iron deficiency, correct iron deficiency with IV iron. That's pillar 1. During chemotherapy, we treat functional iron deficiency with erythropoietin stimulating agent and IV iron, and reduce blood taking. That's pillar 2. Yeah. And after chemotherapy, we accept a lower hemoglobin level, and we give her a bolus dose of erythropoietin stimulating agent and IV iron before discharge and before bringing her back, for her next chemo in a week's time. So that's pillar 1, pillar 2, pillar 3 that we follow, during the course of treatment for this patient. So case 2, we come on to case 2. It's a 65-year-old Malay lady, presented with generalized swelling in July 2016, and she was diagnosed to have nephrotic syndrome, and the biopsy showed minimal change glomerulonephritis. She was noted to have a high hemoglobin of 19.8, hematocrit of 61.2%, white blood cell 11.2, platelet 456, and a creatinine of 53. So we sent a JAK2, and that came back positive. She also had a bone marrow examination done. The diagnosis confirmed polycythemia rubra vera, and she was started on oral hydroxyurea and cardioprin. And she remained well on follow-up with a hematocrit between 45 to 50%. Yeah, that was, then she came back 3 years later with a hemoglobin of 11.5. Yeah, a lower hemoglobin and a hematocrit of 35%. And a white blood cell count of 14.8, platelet of 599. And clinically, she was pale. There was no palpable or enlarged spleen on ultrasound. So this was a blood film. Yeah, as you can see, there's a nucleated red blood cell. It's teardrop. Yeah, sorry, maybe I can show. This is nucleated red cells. The nucleated red cell. That's teardrop, and these two are blasts. Yeah, yeah, and these are platelets. Yeah, so and this is a large platelet, and her red blood cells looks like there is a dimorphic picture. Some cells are pale, some are small, some are large. Yeah, some are large like this. It's a dimorphic picture. A bone marrow biopsy was then also done, and which showed hypercellular bone marrow aspirate with no increase in blasts. This is CD34 stain. This is the megakaryocytes in clusters, and this is the reticulin stain showing that there is fibrosis. Yeah. Then we also sent the 37 gene next gen sequencing and found a new TET2 somatic variant mutation. So, so this points to progression of this disease. So she was started on JAK2 inhibitor, which is ruxolitinib. Yeah. And however, hemoglobin continued to fall. Hence, hydroxyurea was reduced, thalidomide was added on, zinc copper, which is oral iron, was added, hydroquinone was continued, and she was started on erythropoietin 10,000 units once per week. She actually came to see me early in January. Okay, so this is her full blood count trend. So when she was started on a JAK2 inhibitor, hemoglobin was 10.2. Yeah, and that actually fell to 9.4. That's when she was started on erythropoietin stimulating agent. So she came to see me in early January at my home, actually, because she knows she wanted a second opinion. So she came over to my home in early January. And I suggested that we should, start, she should be on IV iron as well, because this points to iron deficiency anemia. So I told her to get an iron iron studies done, and also to actually look for a source of bleeding, right? However, she came back later towards the end of January with a further drop in hemoglobin up to 7.3, and she was transfused with 1 unit of packed red blood cells in the by the treating hematologist. Yeah. So what could be the cause of a drop in hemoglobin? Could it be the effect of the cytoreductive agent, progression of disease, transformation of disease to blast crisis, or occult bleeding? It could be a combination of any one of these, right? But we should always look for any bleeding. Yeah. So the iron studies was only sent in February, and her serum iron was low. Yeah. T-sats was low. Ferritin, of course, is acute phase reactant, was high. And the reticulated hemoglobin was 26, which is low. Yeah. Anything below 30 is iron deficiency. Yeah. And the stool occult blood was positive. Yeah. So she has some bleeding somewhere. So she she went on to have an OGDS, upper scope, which found an erythematous and edematous mucosa with erosive pangastritis and a peptic ulcer and an ulcer in the antrum. So the diagnosis was peptic ulcer disease, and she was started on lansoprazole. There was no active bleeding at that time. She also had a colonoscopy, which showed 2 small ulcers in the terminal ileum, and the biopsy came back as benign ulcer. So the lessons learned from case 2 is to not always assume that the anemia is due to underlying hematological disease. Look for other causes of anemia, and it's important to screen for iron deficiency in patients with malignancy. Yeah, that's pillar 1. Yeah. So in summary, yeah, anemia is common in cancers. solid cancers as well as hematological malignancies, and increases with chemotherapy. Iron deficiency, both absolute and functional, is the most common cause of cancer-associated anemia and chemotherapy-induced anemia. It is important to screen for iron deficiency and anemia in patients with cancer. Yeah, it should be routinely done. And anemia negatively impacts survival and reduces quality of life. IV iron improves erythropoiesis and reduces the need for blood transfusion in patients undergoing chemotherapy, as I've shown in the first case. So with that, I'd like to end with this slide to say that iron deficiency is everyone's business, and in oncology, it's as high as 50%. And you can see in hematological malignancies, as high as 80% of patients suffer from iron deficiency. Yeah. With that, I thank you. That's the end of my presentation.
Thank you, Dr. Sattar. Our next speaker will be Dr. Patricia Ford, speaking on erythropoietin for the cancer patient, to give or not to give. Dr. Ford is an associate clinical professor at the University of Pennsylvania School of Medicine in Philadelphia. She's a member of the medical staff at Pennsylvania Hospital in the Division of Hematology and Oncology. She's the medical director of the Center for Transfusion-Free Medicine and medical director for the autologous transplant program, for which she performed the world's first and largest series of transplants without blood product support to Jehovah's Witnesses. She is also the medical director of the clinical research unit at Pennsylvania Hospital. She received her medical degree at the University of Miami and completed her postgraduate training in medicine and a fellowship in hematology oncology at the Fox Chase Cancer Center. She's board certified in internal medicine and both hematology and oncology. She's a founding member and past president of SABM. She's currently a member of the American Society of Clinical Oncology, the American Society of Hematology. Her areas of interest in oncology are bone marrow transplant and the treatment of women with breast and gynecologic malignancies. She's also focused on patient blood management and alternatives to transfusion support. She has an interest in benign hematology, including the diagnosis and treatment of anemia, especially iron deficiency in pregnancy, managing coagulopathies, and thrombosis. Welcome, Dr. Ford.
Thank you very much. Yes, I will. So thank you so much for that nice introduction. Let me share this. And let's go up top. Yeah, it's kind of hiding it, isn't it? I'm running into the same problem as our other one. So let me find our first speaker. It kind of hides your slides. So let's. It'll be up there. Let's try this one. No.
Under slideshow usually?
Yes, it's up top, and I'm running into the same thing. It's kind of hidden, but let me do.
You have it down at the bottom. See at the bottom next to the volume.
Yep, let's go down there and see what's down there.
The very first one, next to the volume.
Down to the volume now. Let's try down here.
Yes.
Yep. Okay, thank you. Thank you very much for that nice introduction. And this was great. Those first two discussions were wonderful because they really do put a nice segue into what I want to talk about, which is erythropoietin for the cancer patient, to give or not to give. My financial disclosures are listed in terms of advisory and consulting. And I just want to start by saying, what is the ongoing dilemma with erythropoietic stimulating agents? Well, if we treat with them, a lot of physicians know that we have potential risk, increasing thromboembolic events and potentially worsening cancer outcome. If we withhold erythropoietic stimulating agents, then we increase the need for transfusions and associated risk. Ongoing anemia symptoms will also cause a decrease in quality of life. And then we have a potential dose reduction, which can worsen cancer outcomes. So if we have to delay our treatment options, obviously that's not good. So our objectives here is going to be to analyze the benefit and risk in the management of associated anemia with ESAs, summarize ASH and ASCO clinical practice guidelines, and then we're also going to look at describing some of the erythropoietic dosing, modification, and concurrent iron deficiency. So you can see how we had some of this already for our discussion, and it was great. I'm just going to kind of highlight and build. So this is kind of a fun slide here, the history of erythropoietic agents. If you look over on the left, you can see the first time there was even a suggestion that there might be a hematopoietic factor controlling red cells was in early 1900s. But it wasn't until 1953 when this factor was confirmed and given the name erythropoietin. And then eventually in the 70s, we found the ability to isolate this protein from urine, and that's going to lead to the cloning of the gene. And then the ability to produce recombinant human erythropoietin, which was FDA approved for the first time in the early 1980s in chronic kidney disease. In 2000, we had second generation FDA approval here in the United States. And then in the early 2000s, we started to see these safety issues emerge with the use of erythropoietin, especially in oncology patients and chronic kidney disease also. There was a large study called the BEST trial, which is breast cancer erythropoietin survival trial. And there was another one reported after that, the ENHANCE trial, which is looking at erythropoietin in head and neck cancer patients. And in both of these, there was a decrease in overall survival and an increase in local regional cancers. I will highlight in these early studies, they targeted very high hemoglobin levels. But this led to a black box warning and the institution of a REMS program, our risk evaluation and mitigation strategy, which was great because it really did have us really fully inform our patients through counseling about the risks and benefits. This was actually lifted in 2017 because at that point, it was felt no longer necessary as providers had demonstrated knowledge of the risks, and there was data supporting the fact that we were using it more appropriately in our practice. And then also moving forward, you can see the FDA approval of biosimilar agents. So let's just talk a little bit about the erythropoietin gene and receptor itself. It is located on chromosome 7. The expression is regulated by hypoxia, and it's produced mainly by the renal cortex. The receptor itself is located on the cell surface of our erythroid progenitor cells. And as you'll see in a couple slides, that leads to promoting survival, proliferation, and differentiation. But quickly we realize this receptor is also expressed in other organs, brain, heart, liver, kidney, and various cancers. This just kind of highlights for you the signaling pathway here for erythropoietin. If you look, you see some very important signaling pathways that are also important in cancer. But here, specifically looking at our erythroid progenitor cells, you can see down the bottom, all these pathways lead to increased proliferation of those cells, survival differentiation, and more proliferation. How about the receptors themselves? So again, on the left was what we just highlighted, but how about in all these other organs that we just talked about that are not cancer? There may actually be some data out there to show that there's some use of erythropoietin in terms of tissue protection. So let's start talking about anemia of inflammation. And that's been highlighted already by our previous speakers, but just to stress again that anemia of chronic disease or inflammation is the second most prevalent anemia, especially common in cancers. As mentioned, prevalent in 40% of our oncology patients, 75 to 90% once we place them on chemotherapy. And because I'm going to be talking about that in the future, and about 90% in those individuals with myelodysplastic syndrome. Our current treatment with erythropoietin has limited response, but we also know that anemia leads to poor quality of life and exposure to transfusion risks. So as mentioned, there's many different causes of cancer-related anemia related to our underlying malignancy, and at times, especially with the hematologic malignancies, hemolysis, and then add on that our cancer treatment with myelosuppressive drugs and radiation. Perfect case study that was just shown, demonstrating there also can be occult blood loss in our cancer patients, which I see a lot in our GYN malignancies that have had cervical cancers, other cancers with ongoing blood loss, and in our GI malignancies. Nutritional deficiencies, as our patients eat a little bit less, get a little more anorectic, we can find B12, folate, and iron deficiency. And occasionally in this older population, you may also be dealing with underlying chronic kidney disease. So this pathophysiology of anemia is related to impaired proliferation and differentiation in our erythroid precursor cells, as well as the inhibitory effects of things that are released by the cancer cells themselves, interferons, tumor necrosis factor, and cytokine-mediated apoptosis. All this leading to a blunted erythropoietin response, and impaired iron hemostasis, why that first presentation was so important. The increased expression of hepcidin causes a downregulation of iron absorption, which makes it very difficult in these patients to really replenish iron stores with oral iron. And there's also this impaired recycling of iron from our macrophages. Hence, you can have a high ferritin level because you got adequate iron stores, but you're just not moving them into the erythroid progenitor cells. And this is just a nice, by Dr. Goodnow, kind of schematic of all that we talked about, showing up the top right, the liver, and the importance of the most important regulator we now know in iron, which is hepcidin, and its impact down the bottom on the bone marrow. So I'm going to start talking a little bit about the American Society of Hematology and American Society of Clinical Oncology updates, but what led them to need a new update? So they put out their first guidelines around 2002, and since then there's been 2 updates. This will be the 3rd. So what caused these societies to say we need to have another update? And it was really based on 3 additional information that came out. Number 1, they wanted to look and see the articles that were more recently published on the use of ESA, and was there anything that had changed in the knowledge we already had? And they added and focused on some of the studies which I'm going to review in metastatic breast cancer and MDS. They also wanted to highlight the role of iron and the benefit in using it with ESAs, and then needed to acknowledge the fact that there was also now an FDA approval of biosimilars. So these guideline updates were an expert panel convened that reviewed randomized controlled trials, which there were 15 new ones since the last update, meta-analysis of randomized controlled trials, of which there were 2 in patients with cancer that were published from 2010 through 2018, and they decided to address what they felt were 10 very relevant clinical questions. Clinical question number 1. To reduce the need for red cell transfusions, should ESAs be offered to patients who have chemotherapy-associated anemia? And in this, there was one study that was also, there were a few studies that they looked at. I'm going to highlight this one here, which is looking at one tumor type, metastatic breast cancer. And remember, I had mentioned one before called the BEST study, and I'll come back to the comparison between that one and this one. So this study here was an open label, non-inferiority study in women with a hemoglobin under 11. And most of the time, the median baseline was 10.5. And these individuals were given erythropoietin, 40,000 units weekly. And they ended up given a median of about 8 doses. And it was randomized against best supportive care, which included iron and transfusion support. And you can see it's a large study. It's 2,098 patients. Their primary outcome that they wanted to look at was progression-free survival. And what they found here was exactly the same, 7.6 months in the ESA treated versus best supportive care groups. They also wanted to look at overall survival. And it was 17.2 versus 17.4 months. So again, you can see not statistically different here. So they felt at this point it did not meet, of course, their non-inferiority criteria. Other secondary outcomes that they looked at were transfusion, decrease in transfusion requirements, and it was low in both groups, surprisingly. In the ESA treated group, it was lower at 5.8%, and in the best supportive care was 11.4%. The median hemoglobin that was achieved was higher in our ESA group at 11.6, and our best supportive care group was 10.9. The other thing they looked at was thrombosis, and it was low in both groups, much lower than some of the original studies that led to the increased risk of thromboembolic events. It was 2.8% in the ESA treated group and 1.4% in the best supportive care group. Anytime the TSAT was under 20%, both groups received iron, and the majority of the time it was oral iron. So what I wanted to highlight here was the fact that compared to that BEST study that was done a number of years ago, why is there a difference? Why did they not see a decrease in overall survival or progression-free survival in this larger study? Well, there's a couple of thoughts. One may be that in the initial study, their use of ESA was well beyond what we would normally be doing now. Right now, we're just looking to correct the anemia and avoid transfusions. So as I'm going to get to, it's not even approved if your hemoglobin is over 10. So the older studies really ran the hemoglobins much, much higher with ESAs. Why could the thrombosis be lower? One thought is that in this study, there was an extremely strict definition of what constituted thrombosis rather. So they did not include, for instance, something that was more likely superficial phlebitis. So the recommendation from this was that ESAs can be offered to patients with chemotherapy-associated anemia if there is no curative intent and if the hemoglobin is under 10 grams. So this was just nothing new was found in terms of the risks, essentially, and they kept their kind of recommendations very attuned to the ESA guidelines before. Clinical question number 2. To reduce the need for red cell transfusions, should ESA be offered also to anemic patients with cancer who are not receiving any concurrent myelosuppressive chemotherapy? And really, I wanted to stop again just to highlight the difference between hematologic malignancies and solid tumors, because there can be differences here. Certainly in our solid tumors, it can be a direct effect of the cancer itself from bleeding, as I mentioned in GYN, GYN. So you may be dealing with a larger component of absolute iron deficiency here. Usually the nutritional deficiency can be more common in our GI tumors that are associated with malabsorption. And the thing to highlight in some of the hematologic malignancies and disorders is you have bone marrow infiltration, our leukemias, our lymphomas, our myelomas. You can also have hemolytic anemia, autoantibodies, microangiopathy, and amyloid production. So there are some other reasons to add on why we could have anemia in our hematologic malignancies. And why I bring this up is in this recommendation, they now wanted to look at myelodysplastic syndrome. So remember with myelodysplastic syndrome, this disease, it's very common in our low-risk population. For the most common thing that we're dealing with is symptomatic anemia. And ESAs are our standard of care. Now, in the 5q deleted patients, we use lenalidomide as a treatment option because we know that lenalidomide is cytotoxic to the MDS clone. So that population was not allowed in this study. So as you can see, they're going to look at lenalidomide with or without ESAs in patients that are transfusion dependent and have already been exposed to ESAs and are refractory, but are still in our lower risk MDS. So in this study, randomized phase 3, they looked at about 131 patients that were transfusion dependent, getting upwards to 6 units of blood in over a 2-month period. Everybody got lenalidomide, and then it was randomized with or without erythropoietin at 60,000 units per week. And what they found was that the transfusion independence rate was much higher when erythropoietin was added to this difficult to treat transfusion dependent and refractory population. And remember, in MDS, these patients are anticipated to have a very long survival. So we want to try to avoid transfusions and the risk of iron overload, which is another very important complication in this patient population. So the recommendation for this clinical question was that ESA should not be offered to most patients with without chemotherapy-associated anemia, with an exception of lower risk MDS, and in that case also found to be most beneficial when the erythropoietin level was under 500. Their next clinical question was, what special considerations apply to adult patients with non-myeloid hematologic malignancies receiving concurrent myelosuppressive chemotherapy? And here what they wanted to look at is our hematologic malignancies, multiple myeloma, non-Hodgkin's lymphoma, CLL. And what they wanted to highlight here first was try treating before you're going to add on ESA for the anemia, because these diseases can be very responsive to all the new agents that we have. And, all of us have examples in those who decline transfusion, presenting with very profound anemias. I'm treating someone right now who's a Jehovah's Witness with a new diagnosis of multiple myeloma, coming in with profound anemia, hemoglobin just under 4 grams per deciliter. And in that individual, they're getting a very nice response with steroids and my non-myelosuppressive agents. And already I have a hemoglobin without ESA, without iron replacement, just with treatment up to a hemoglobin of 8, which will allow me to come in with more cytotoxic agents. And also in this population, they're just highlighting again, even more caution because of the thromboembolic risk. Think about some of these diseases and the strategies we use, like lenalidomide, that do increase thrombotic risk. Question number 4. What examination and diagnostic tests should be performed before making your decision about using ESA to help us identify patients who are likely to benefit? So what they're trying to do here is really, as has been discussed, look at, are you sure you don't have an alternative reason for your anemia? Great case study, exclude occult blood loss, renal insufficiency, hypothyroidism, and of course, like we all do, evaluate for hemolysis or underlying hemoglobinopathy, along with the basic things we do, which is iron, folate, B12, reticulocyte count, and review of our peripheral smear. So again, they just really wanted to highlight to make sure that we're identifying alternative causes of anemia. Clinical question number 5. Among adult patients who receive an ESA for chemotherapy-associated anemia, is there any difference between the many different agents we have available now and the currently available biosimilars? And is there any difference in respect to safety or efficacy? So here they actually, when they looked at the biosimilars, I'll just highlight the fact that they included a few studies, randomized clinical trials with CKD only. They just needed to get more robust information on our biosimilars. And I'll stress the fact there's limited evidence, but these agents have been more widely used and longer history in Europe than here in the United States. And of course, for all of these, how we make the decision is if they're all equivalent, and that was what they decided on review, is that there was no difference in efficacy or safety. We now have a choice, and we all use the choices we have available to us based on cost. It may be cost factor, availability, or convenience from some of our longer acting agents. But again, to highlight, no difference in efficacy or safety. Clinical question number 6, do ESAs increase the risk of thromboembolism? So we've known this since the early 2000s, and what they wanted to do was just see if there was any new information that came out. And essentially, I'll highlight this one, which is one of the new studies that they looked at from Gal. This looked at 12,000 patients, venous thromboembolism and ESAs for the treatment of cancer-associated anemia. This is a meta-analysis. And they're looking at the incidence of VTEs, and you can see with ESAs, 7.7%, our control, 4.7%. Now, remember the study I presented with breast cancer? That also was a large number of patients. It was, just one study. But why are all these differences there? So one thing with you're looking through all this robust data is to keep in mind, not many of them. There's so many different cancer types. So we don't have a lot of information on individual cancer types and the effect of ESA and the ESA risks. So we do see differences here. And the other thing is when we get to it, a lot of the earlier studies especially did not really differentiate between curative and palliative intent, which is where we're restricted in our use of ESA. They did highlight the fact that our highest risk of VTE, again, was with hematologic malignancies, and they also broke down ovarian and cervical cancer, our GYN malignancies. So the recommendation here was there was no difference in the data in terms of the increased risk that is seen with the ESAs, and that we should continue to use that with caution. Clinical question number 7. Among adult patients who will receive an ESA for chemotherapy-associated anemia, are there any change in the recommendations for ESA dosing and dose modifications? So there's not. The recommendation was to continue to follow the FDA guidelines, in terms of dose increasing, reductions, withholding, and discontinuing. And I think another thing to highlight in a lot of these studies, yes, the dosing is different, so it's hard to do any comparison. In a lot of the older studies, some experts have said that was the reason they may have seen such a high rate in the VTEs, especially, was they were running the hemoglobin way higher than it needed to be, with targets upwards to 14 and 15 in some of those studies. And we've learned from that, we want to keep the dose what is absolutely necessary to avoid transfusions and not to overshoot. And we want to decrease the dose when we reach a level to avoid the transfusions, or when our hemoglobin increases 1 gram per deciliter in 2 weeks. Because another thought is that there may also be a too rapid increase in the hemoglobin, may also be leading to some of these VTEs. Their clinical question number 8. Among adult patients who will receive an ESA for chemotherapy-associated anemia, what is the recommended target hemoglobin? Do we have a recommended target hemoglobin? Remember, their ESA guideline is that we start only when our hemoglobin is under 10, and we use it only in the non-curative setting. So they did not come up with an optimal hemoglobin defined, other than to say the target should be the lowest dose, the lowest hemoglobin, you need to avoid or reduce red cell transfusions. And to strongly consider modifying your dose when your hemoglobin exceeds 1 gram per deciliter increase in any 2-week period, a too rapid rise in that hemoglobin rate. Question number 9 out of 10. Among adult patients with chemotherapy-associated anemia who do not respond to ESA therapy, and that definition is a 1 to 2 gram increase in hemoglobin or no decrease in your transfusion requirements, is there any benefit to continuing ESA therapy beyond 8 weeks to provide a benefit? And the recommendation is there should not be continuation if you have no response in your patients beyond 6 to 8 weeks. And as we've mentioned before, of course, at this point, you're also going to be, again, looking at alternative causes for your anemia. The last question. Among adult patients with chemotherapy-associated anemia, does iron supplementation concurrent with ESAs reduce your transfusion requirements? And as been mentioned, we now know a lot more about absolute versus functional iron deficiency, and we do see absolute iron deficiency in this patient population. I mean, of course, we're used to it. For those of us who treat a lot of women with GYN issues and heavy uterine bleeding, we're used to seeing our ferritins of 1 and 2 with our profound anemias, but you can also see absolute iron deficiency in our patient population of cancer patients. Functional iron deficiency also incorporates iron-restricted erythropoiesis. So as we're giving erythropoietin, we need to make sure, even if we started with adequate iron stores, we're likely to outstrip that if we don't give available IV iron necessary for that enhanced red cell production. So looking again, a few studies were already highlighted in terms of iron supplementation, adding it on to ESAs. I just listed a few here. And let's look at Petrelli's, the addition of iron to erythropoietic stimulating agents in cancer patients. This is a meta-analysis of 8 trials. And the comparator here was no iron versus oral iron versus parenteral iron. Over 1,600 patients out of these 8 trials. And what they showed here was there was an improvement in hematopoietic response with parenteral iron much higher than for oral iron. And the risk of transfusion was reduced with parenteral iron, but not with oral iron. So parenteral iron preferred. And the time to reach hematopoietic response was much shorter, over 1 month, with iron supplementation. So overall, parenteral iron reduced the risk of transfusion, increased the chance of hematopoietic response when compared with ESAs alone. Oral iron did not increase hematopoietic response nor decrease our transfusion rate. And think about it, that makes sense in terms of what we all know now about functional iron deficiency and decreased iron absorption. And the significance of this result is the proportion of non-responders to ESAs will have strongly improved and quality of life and cost ameliorated if we can add iron, parenteral iron, and get our response. looking at a subgroup analysis and a concurrent review, looking at 8 randomized clinical trials, comparing ESA plus iron versus ESA alone over 2,000 participants, again, highlighting almost the same thing, the beneficial effect of iron supplementation to ESAs, decrease in red cell transfusion, and in their subgroup analysis, the fact that intravenous iron was favored over oral iron. Their author's conclusion is highlighting what we've already seen, the addition of iron to ESAs will give you a superior hematopoietic response, decrease your risk of red cell transfusion, improve your hemoglobin level, and appears to be extremely well tolerated. With no evidence, unfortunately, in some of these, it varies for a difference in quality of life with iron supplementation. This is just looking at what's our future look like. So even this slide is a little outdated already. What are some new compounds under development you should keep your eye out for that may supplant ESAs or assist with ESAs? So as we're learning more and more about hepcidin, that may be a mechanism that we can target. As we're learning more and more about the whole pathway of iron and more about erythropoietin and receptors. So there's a lot on the horizon here and compounds that are under the development for the treatment of inflammation and malignancies. So in conclusion, the use of ESAs to manage chemotherapy-associated anemia will raise the hemoglobin level, decrease your transfusions, but does come with an increased risk of thromboembolic events that we need to be very cautious about. We have guidelines that have been updated supporting the offering of ESAs in a non-curative setting and when the hemoglobin is under 10. Adding iron to treatment with ESAs may improve the hematopoietic response or reduce transfusion. And I think ongoing studies are really needed to look at different malignancies, which may render different responses. And we need to be very careful to look at these studies and have it randomized so that we know if it's being given, if our chemotherapy is being given in a curative or a palliative setting. So thank you very much.
Thank you, Dr. Patricia Ford, for really elaborate, extensive talk with all the recent evidence. Yeah, so now I will open the floor to question and answers. So I think I will look through all the Q&A questions. Can I address the first question to Dr. Rafai? Is everyone, could I invite all the panel, all the speakers?
Sure. Yeah, I'm here.
Hi. Yeah, I think there's first question someone was asking, is it necessary to measure the 2,3 DBG in order to decide whether to transfuse or not?
It's not really necessary. Absolutely not. I mean, this is something. It's a red blood cell enzyme that's helping binding and releasing oxygen in the normal red blood cells. When they store, the storage reduce this enzyme in the red blood cells and actually not only produce, I think the entire enzyme just disregarded. And in this case, it's not going to regenerate. So that's why the transfused red blood cells that have the higher capacity to bind to oxygen and not releasing it. There's absolutely no need to measure this. I mean, I'm very sure there's a lot of methods that you can measure it if needed, but it's not needed neither in the patients nor in the unit. Just be aware that this reduction in the DBG is not reversible in this unit, and it will definitely cause affect the oxygenation in the tissue, especially in pediatrics patients.
Thank you, Dr. Rafai. Second question, I think someone was asking about the difference between the erythropoietin and dapapoietin. Maybe Dr. Patricia Ford, since you are talking about erythropoietin.
Yep, so there's no difference other than the convenience of the scheduling. So no difference in efficacy or toxicity. Certainly when you're using erythropoietin agents, you have the glycosylated ones, which can be given every 3 weeks, which many times will time with your chemotherapy regimen, and that would be preferred. But I don't know about other states, but I know here I'm very limited sometimes in what I'm allowed to prescribe. Sometimes I'm not allowed to give a long-acting agent. I can only give a weekly agent, and many times it has to be a biosimilar. So it really, nowadays, more than ever, goes through my billing department, who then comes back and say, change what you've just ordered. So, but no difference in safety or efficacy in any of these agents. It really is cost, convenience, patient preference. Right.
Right. Dr. Jamila, someone is asking about, should we wait for the sepsis to be subsided before giving IV iron in cancer patients with iron deficiency anemia? You're muted, Dr. Jamila.
Okay. I think, yeah, everybody is worried about IV iron causing sepsis or increasing the risk of infection. Well, studies, I mean, the evidence is, controversial. Yeah, of course, if there is an active infection going on, you should treat with antibiotics. And once the infection has subsided, it's okay. I would go ahead and give the IV iron. Yeah. If you're thinking of giving blood transfusion also, there is also a risk of infection, right? So which is better? Yeah. IV iron, definitely, right? Yeah.
So I think I opened this question to three speakers, who is going to be able to answer. So if a patient is suffering from extremely low hemoglobin due to aplastic anemia and is on erythropoietin, the iron stores and iron is all above normal, would you still be giving IV iron? Currently, she's approaching sirolimus target level. I think, I'm not sure is this true or not. The hemoglobin is stated here 23. Anyone? Who would like to answer these questions?
I mean, the thing that you worry is, if iron stores are adequate, I wouldn't give IV iron. Of course, you need to monitor because, with erythropoietin, your iron may go down, but I would not give unless patient is iron deficient. What do you say, Patricia?
So I agree. Our guidelines suggest you can, if you let's just use ferritin first, because of course that's always the hardest one because it's an inflammatory protein. It can be elevated and you can still be iron deficient. But you can give it all the way up to a ferritin level of 500 if you have, a TSAT that's low or other evidence of iron. So that we have complicated guidelines that Ash put out, but it kind of is a little table that helps you kind of sort that out, looking at your iron studies and whether there would be a potential benefit. But if you've determined there's no iron deficiency, you got to monitor, I agree, when you're starting erythropoietin, because you will run out of iron and you will need it eventually. But if you're starting here and your iron stores are just fine, I agree with you. But there are guidelines out there that suggest you could have a benefit up to ferritin of 500.
Right. So now, another question. Are epigenetic drugs a viable options in patients who may not be able to undergo conventional chemotherapy due to severe anemia? Anyone? Dr. Rafai? No?
This became like an option for the treatment of the cancer itself. I would definitely try to treat the anemia and then use the most effective medication for the cancer. So in this case, if the chemotherapy is indicated, absolutely we'll have to go to the chemotherapy, but you just make sure to fix the anemia before you start your chemotherapy. A 3-4 weeks delay in the chemotherapy, which is more effective, won't hurt much. But if you start treating the chemotherapy on top of the anemia, that's going to make it worse. So I would just try to delay it, and always effective therapy is much better approach. And anemia in most cases are fixable, but just need to plan ahead of time.
I absolutely agree. When you're dealing with profound anemia, and your patient is unable to be transfused, there really is no specific guidelines, just you have to be extremely willing to use a lot of non-myelosuppressive agents, targeted agents, and anything you can think of just to start getting some tumor shrinkage, and then hopefully your anemia will improve while supporting them with growth factors. But agree with these, acute leukemia and some of these other hematologic malignancies is very difficult. So I just start out sometimes with 25% of a drug, along with my non-myelosuppressives. Get in as much as I can.
Yeah, Dr. Freud, yeah, someone is addressing the question. If a patient's be high risk of VTE, would you start with a low dose erythropoietin stimulating agent? Would it make a difference if a low dose?
Oh, so is it dose dependent? Okay, so I get it. So a couple of thoughts with this question here. So I'll start with a different answer, which is number one, nobody's really looked at, do you give prophylactic anticoagulation? And no one has really looked at that. So we don't have that answer to just do it prophylactically. It depends on the scenario. So I do have individuals that I have to give erythropoietin to, like that hemoglobin of 3 or 4, in somebody who's at high risk, and we talk about that. So that really is part of our whole kind of old school REMS counseling, having the patients involved. So I wouldn't preclude giving ESA in somebody who has a high risk. They've tried to do risk scoring for us, different things we can do to get a score of somebody's risk factor. But I would use it with extreme caution. So I'm using it much less liberally than I ever did before over this last decade, honestly. But I'm still using erythropoietin. I'm using IV iron a lot more than I ever did before. So I've kind of really switched even my own practice. But there's sometimes I personally, treating a lot of Jehovah's Witnesses, I don't have a choice. I got to use an ESA and then, caution them and look more consistently for an ongoing thrombosis. But nothing prophylactic has ever been looked at or proven.
Right. How about Dr. Jamila? What do you think? Someone was asking, anything can be done to combat thromboembolic risk?
I think the etiology or the predisposing factors for thromboembolism in patients with cancer is multifactorial. Yeah. Yeah. I don't think we can just blame it on erythropoietin. I think if you can control the disease, then actually most of these patients are also on prophylaxis with VT prophylaxis for low molecular weight heparin. So I don't really, actually in my practice, I don't really see a high risk of thromboembolism in my patients on erythropoietin, because most of these patients are already on some form of VT prophylaxis. Yeah.
Here comes the last question, I hope. I have read in general in animal models, erythropoietin may increase the proliferation of cancer cells and tumor growth by alternative mechanism. How this could be managed if the same things happens for cancer patients?
So you're right. There's a lot of
Looks like
preclinical studies that led to all of our concerns in the early 2000s. That is absolutely true. When we discovered the erythropoietin receptor is located not just on erythroid progenitor cells, but on other organs and cancer cells. So that's how that whole thought process started, when they discovered the receptor on cancer cells, and then the studies that were showing an increased risk of cancer recurrence and local, regional, and metastatic. So it is a concern that there may be, unfortunately, some tumor growth associated with the ESAs. But which tumor? Here we go again. What cancer type? So I can only say that all the studies do show, the majority of them anyway, a slight increase in cancer recurrence. And that led to the recommendation strongly of, don't use it in a curative setting.
But you would think that the erythroid precursors would have a higher, affinity, the receptors have high affinity for erythropoietin rather than the other cancer cells, right?
No, you're absolutely right. What's the expression of the
Yeah.
receptor is higher,
Yes.
and I agree. It is
Yeah.
not as robust, but you could have a mild stimulatory effect on cancer cells. So it is a concern.
Just my Dr. Rafai, my own knowledge, I'd like to ask. Just now you showed the data on using IVI and erythropoietin stimulating agent in the autologous stem cell transplant. I just want to ask whether you have experience in using allogenic stem cell transplant as well.
Well, I'm not a clinical physician, so I don't deal with these patients a lot. I mean, to be honest with you, I did not see any during my preparation for this talk. I did not see anybody touch base on that. But again, it just go back to the treating of anemia in general, regardless of the condition. Definitely IV iron and ESA, if needed, should be considered. Now, one more thing, actually, I want to ask both of you, Jamila, Dr. Father, and Dr. Ford. Do you ever consider oral iron, or are there some cases where you put your patients on a long term of oral iron in these patients, or is it not effective?
I'll let you go first. Yep.
Yep, you go. Patricia, you go first.
So I rarely use oral
Okay.
iron. So I rarely use oral iron unless it is a non-cancer patient. Then I absolutely use it. It is cheaper, it is safer, it's more convenient. If I have absolute iron deficiency, I will start with the oral iron and then go to parental if they can't tolerate, which is 40% of the time. And in our cancer patients, it is tough. They're already nauseated. They're already on other agent. It's just tough for them to take oral iron. And I think it's going to be ineffective. I'm not going to get a quick response. I think I'm not going to overcome the functional iron deficiency. So in cancer patients, I do not use oral iron. But I think it is an option. It's an option.
I would use it if once they have completed chemotherapy, once they have completed chemotherapy, they're remission, they're still iron deficient, then we consider giving oral iron, but I don't see it to be effective in patients with active cancer and who's on chemotherapy. So I'll use IVI.
And every one of the studies show the benefit of parental iron over oral iron.
Yeah.
No, I mean, during my review of all the literature preparing this talk, I did not see any one actually did emphasize on oral iron. But I agree with you guys. If it's a chronic therapy after the fact, yeah, you could definitely use this. But you need to fix the anemia as early as possible in order for you to start therapy. So it does make sense. Yeah.
Just had another question.
Dr. Nathaniel says, Nathaniel did say that he uses, what did he say? Oral iron in between, chemotherapy.
Yeah, I think that's a great strategy. If you think about it, every little squirt of iron you give at the gas station can't hurt. But with the newer agents, I can replenish their total iron stores within 1 or 2 infusions compared to a month or 2 of oral iron. But every little bit helps. So that's actually a nice strategy too.
And also you have to pay attention that, I mean, I'm not sure if everybody is aware of this, but there was a study published about oral iron that it's better and more effective if you use
Every other
day or every third day even.
Yep.
Because this will give a chance to the enzyme to increase, which help absorbing of the iron from the cuts. So maybe every other day or every third day. That's first of all a guarantee higher absorption of the iron and less complications of the GI tract with iron. So less constipation if you avoid a day or 2 between doses. But that's a very good policy here for treating in between the chemotherapy.
Another question, 2 more questions coming in. I hope we got some time still. Yeah, Victoria, we still got time, right?
Yeah, I think we have a few minutes.
So someone is asking, I want to know if your countries, the treatment with erythropoietin stimulating agent is 100% free of charge in public healthcare, in private or not? I think that's a tough question to answer.
It's horrible for us in the United States, I think. And maybe it's just, and it's also state dependent, it's insurance dependent. It's what, even if you have the same insurance, what you've signed up for, in terms of outpatient injectables in office. So that's why I have, for smaller practice, we have like 6 coders and billers. So the first thing that's done whenever I order anything, it has to go through the billers, and then they'll come back and tell me what is the least out-of-pocket expense for the patient and what the insurance will cover. So it is so variable. Has it ever not been covered? That has not been the case that I've found, although the cost out of pocket is different for each patient.
What do you think, Dr. Jamila? I think we have it for free in a public sector.
We are heavily
Right.
subsidized now.
That's
Yeah,
right.
in our government hospitals.
The taxpayers
But you
actually.
can see that we don't use the higher strength so often because it's more expensive. Yeah, so we use smaller dose 3 times a week, Yeah.
Right. There's another question. Is the use of oral iron in cancer therapy restricted, though, with absolute iron deficiency due to the action of hepcidin and IV iron bypassing the sequestering system of the body? I think they're trying to ask in relation to the hepcidin hormonal homeostasis in terms of the absorption of oral iron. I think that is it. I think just now Dr. Rafai has explained
Yep, I mean,
that hepcidin.
as I said, the hepcidin is needed for the absorption of the PO iron. But definitely IV iron, you don't need to worry about it in this case.
Right. I think that's generally it. I think Dr. Jamila has answered the question of folic acid. Someone has posted it twice. The use of folic acid in cancer.
This folic acid, do we routinely use folic acid in our patients? I mean, just like all vitamins, B12, folic acid, I mean, and the myth is that we are feeding the cancer cells, right? If you give all these vitamins, I don't know. But I see no harm in giving vitamins, especially when patients are not actually eating well, Yeah. What do you think, Patricia? Do you routinely give folic acid to your patients?
So I do not routinely give it, and you're right, it's hard to even measure to see if you're really folate, deficient or not. But even though I do measure it, I find B12 much more commonly, obviously. But in terms of any of the supplements, you're right. I don't know how that may interfere with my treatment. So without any basis, we have a lot of our patients that actually participate in a complementary center, which is very good. They're getting vitamin C, they're getting miso, they're getting a lot of alternative or complementary therapies. And we've decided together to just hold it 2 days before treatment, 2 days after, because I don't know what effect it could have on what I'm trying to do in terms of, myelotoxic effects and cancer.
I think because, some of the chemotherapy has anti-folate effects, right? Yeah. To circumvent that, I think. Yeah.
Primotrexate, you have to give it automatically. So Alimta or Primotrexate, we automatically give it as a replacement.
We give folic acid,
Folic acid. Study I reviewed when I did this talk is basically giving folic acid to manage to avoid transfusion. So yes, it can be given at some times.
All right. I think there's a lot of questions that all these 3 prominent speakers have answered. Yeah, Victoria.
Right. Yeah, I think
So
that sums up our Q&A, right? Yeah, thank you to our speakers for those excellent talks and the discussion time. So now we're going to segue into our industry speaker presentation. So I think Sam from, let me just find the company from Pharma Nutra is going to talk about oral iron. So Sam, are you on the line?
Yes. Thank you so much, Victoria. Can you guys hear me?
Yes.
Excellent. Well,
loud and
thank
clear.
you so much for the introduction. I appreciate the opportunity to connect with you all today. Thanks to Sandy for the invitation. So can you guys see my screen here? Okay, excellent. So I have a number of slides. I'll try to keep it obviously to the 10 minutes and then 5 minutes for the Q&A. So a little background. My name's Sam Sparhawk. I'm the National Commercial Manager for Pharma Nutra. We are a Italian-based nutraceutical company based in Pisa, Italy. We've been around since 2003. We're in 70 different countries throughout the world, throughout Europe, South America, Asia as well. And I'm lucky enough to be a part of the US launch. We launched in September of last year. And yeah, it's certainly not a novelty product around the world. Every day there's about 1 million people that take our sucrosomial iron, our oral iron. So it's exciting to share it with you today. So a little background, the founder of our company is a lipidologist and a nutritionist. And 15 years ago, he created this unique technology that essentially protects iron throughout the GI tract so it doesn't get exposed in the upper GI. It's called a sucrosome. If you go to PubMed or Google Scholar and you search sucrosomial iron, you'll see about 10 to 12 pages of data. We are the most studied and most researched oral iron in the world. So we have an abundance of clinical studies elucidating the efficacy of the product. But essentially, it's iron pyrophosphate wrapped with that bright yellow layer. That's a liposomal layer. And then the additional layer is what makes us unique. It's sucrose esters esterified with fatty acids. So that makes it completely guarded in the GI tract. That combination is patented. We are the only company that has it. And it's useful in a clinical setting because the iron is not exposed at all throughout the GI tract. The byproduct of that is increased absorption and bioavailability, and then better compliance due to the lack of side effects. The iron does not oxidize in the GI tract. It doesn't interact with the intestinal mucosa. So essentially, you're avoiding for your patients all of those compliance issues because it has a higher tolerability. They're more likely to stick with it. There's no metallic taste or appearance. So as you can see here on the left, it's almost like a cream white-like powder compared to the conventional iron on the right. You can see it's oxidized. So we're avoiding all of those typical GI side effects, including even the teeth staining that comes with iron gluconate. So all of the usual drawbacks of oral iron. So the reduced outcome, the alteration of the microbiome, the dark stool, the poor patient compliance, and then obviously the treatment dropout and the lack of outcome. In speaking with PBM and bloodless programs at hospitals, we hear that the conventional format is the patient has to try an oral iron before they can get coverage for IV. And there seems to be a frustration with that oral iron treatment time, just knowing that more often than not, it's going to be ineffective. The patient's going to fail because of those side effects, and they're going to end up getting infused anyway. So where we fit in is as a frontline therapy to avoid that lost treatment time where the patient needs to try an oral iron before getting infused. This is a snapshot. We have a review published in Pharmaceuticals, and this is a snapshot of all of our research up to May of last year across different specialties. This is the incidence of GI side effects. So of 2,000 patients, the average rate of those GI disturbances was 4.5%, so extremely low, where you're looking at a sulfate or a gluconate, these traditional oral irons that are cheap, but they have upwards of 70% of patients experiencing a GI side effect. So compliance obviously becomes an issue. So we're absorbed differently than typical PO iron. So 3 different pathways to maximize our absorption. So one is through the enterocyte via endocytosis, independent of that typical DMT1 ferroportin channel between the enterocytes, and then via M cells. So this is important when a patient is inflamed and the typical transport is ineffective. These microfold cells that line the small intestine, they essentially engulf the sucrosomial iron fully intact via phagocytosis. The sucrosomial iron then travels through the lymphatic stream. So whether it's through the M cells via the lymphatic stream or through the enterocytes and through the bloodstream, the sucrosomial iron eventually reaches the liver. And in the liver, lysosomal enzymes break down that sucrosomial layer, and the iron pyrophosphate is freed, and it binds for transferrin. Ferric form has a high affinity for transferrin, so that's why we chose that form. And it goes to the bone marrow for hemoglobin production. So we have the preclinical data showing this mechanism of action. On the left, you can see the gastric resistance, so stimulating the upper GI. The red line on the bottom is essentially showing compared to a non-sucrosomial form. It's not being broken down at all over the course of 120 minutes. And then on the right, the 2 graphs show the absorption compared to conventional iron. So you can see in the middle, that's enterocyte increase in ferritin. So we're about 3 to 4 times higher absorption than conventional iron. And then on the very right, you can see the M cell absorption. That's the red line. The green line is the enterocyte absorption. So a significant difference compared to conventional iron. So all 3 pathways, this is very important, are completely independent of the DMT1 ferroportin channel. So why is that important? When a patient is inflamed and hepcidin is an issue, signaling for iron to be stored in enterocytes and hepatocytes instead of circulated, we are still effective at increasing hemoglobin. So if a patient has let's say a ferritin of 200 plus and a transferrin saturation below 20%, we're still effective in that patient type, whether it's an autoimmune disorder, anemia of chronic disease, we still have a positive impact on the hemoglobin. So this is a snapshot of where we're published. So we're published in international journals, the American Journal of Hematology, European Journal of Heart Failure, and then the review I mentioned in Pharmaceuticals. But again, if you go to Google Scholar or PubMed and you search sucrosomial iron, you'll see about 10 to 12 pages of our data. And these are the various specialties where we have research published. So we run the gamut, from gastroenterology to surgery and PBM, oncology as well. So it's a product that's studied in all patient types and proven to be efficacious in each one. And then a snapshot, we have 41 full papers published, and then 6 full abstract books. So the clinical data, again, is there. And then I have a few studies. I'm going to quickly run through these for the sake of our window here. The first is a gastric bleeding study. This is essentially encapsulating the difference between our oral iron compared to others. This is a study with 300 patients with GI bleeds. And if you look compared to all the conventional oral irons, we were the only one to have a significant increase in hemoglobin over time, and 4 times faster than conventional irons. We took patients from a hemoglobin of 8 to a 12 in 6 weeks with just 2 capsules per day. And on the bottom, you can see the patients that were shown to have a high CRP. We are the only oral iron to correct the anemia. So again, when hepcidin is an issue and the body is signaling for iron storage over circulating iron, we are still effective So this study looked at, I think it's important to note we have research compared to various IV delivery, whether it's gluconate, ferric carboxymaltose, or sucrose. This study elucidated a dose-dependent impact of the Citarol. This was 4 caps per day compared to daily infusions of IV gluconate at 62.5 milligrams. Patients with a hemoglobin of 8.5. It took 9 days to increase 1 gram per deciliter in the oral iron group versus 7 days for the IV, and then 4 weeks for the increase to the target of 12 grams per deciliter versus 3 in the IV group. And then the cost is obviously significantly cheaper versus the IV group. So a more affordable option for patients. Just have a couple more slides. I know I have to speed up here. So this one compared Citarol to IV gluconate in patients with chronic kidney disease. Of note, 1 capsule per day was a similar increase in hemoglobin compared to weekly infusions of 125 milligrams. I like to point out there were 10 times less adverse events in the oral iron group, 3% versus 34%. And then this study compared Citarol to IV gluconate in conjunction with an ESA. This was 500 micrograms every 3 weeks of an ESA. And of note, both groups had a positive outcome in achieving an erythropoietic response, 70% of the Citarol group and 71% of the IV group. There was also no difference in the transfusion rate among the 2 groups there. And one last slide here. So this study compared Citarol to IV ferric carboxymaltose. So it looked at 2 caps per day for 8 weeks of Citarol, titrating down to 1 cap for the final 4 weeks, 12 weeks total, compared to a baseline IV of ferric carboxymaltose of 1 gram. So you can see a comparable rise in hemoglobin and serum iron. And of note, the ferritin, we did not have the risk of iron overload. To simply put it, Citarol, the sucrosomal iron, acts as an intelligent iron. It corrects the hemoglobin before working on ferritin. So once hemoglobin is corrected and within range, you'll start to see the ferritin increase. So we're avoiding the iron overload or hyperferritinemia. So that's it as far as the slides I have today, but happy to answer any and all questions that the team may have.
Well, thanks for really wonderful introductions to such an amazing oral iron.
My pleasure.
I think there's one question.
Yeah, and I think
What is
someone was
impact-
raising their hand too. Oh, go ahead, Mandy,
Yeah,
sorry.
Sorry. I just want to ask Sam about what about this impact on the iron stores?
Absolutely. So great question. So Citarol acts as an intelligent iron. Essentially, it'll correct the hemoglobin first because of its bioavailability. And then once hemoglobin is within range, 12 plus for females, 13 plus for men, then you start to see the increase in iron stores and that ferritin. And we do have research on patients with a hemoglobin within range, and you see that increase immediately with the ferritin. And I can share any and all data if requested.
I think Victoria said someone raising their hands.
Yeah, I saw it and then I'm not able to see it any longer. If that person's able to unmute themselves or type their question in the chat box, that would be great too. We'll give her a minute. I think it was one of the nurses.
So I do see a question or a statement on the right. So the last slide showed no impact on ferritin level. So again, it'll increase the hemoglobin prior to working on iron storage. So once the hemoglobin is within range, you'll start to see that increase in the ferritin. But the byproduct of that is the risk of iron overload with IB. We're avoiding that ferritin shooting up to 400 to 600.
So I see Abigail Ibarra is raising her hand. You're welcome to unmute if you like, or type your
Okay.
question.
Good afternoon, Sam. Thank you for your nice presentation. Please, I want to ask, because you said your company is the only one producing this iron for now. How do we get it available to all parts of the world, especially here in Nigeria?
Sure. Yep. So we do have a patent on the technology. So we're the only company to produce the sucrosomial form. I'll have to double check on the availability of in Nigeria. Typically, we work with distributors throughout the world. So I can check with our home office in Italy to see about Nigeria. As far as the US, we are available on our website and then on Amazon as well. And then we do work with hospitals at wholesale pricing to be added to formulary at a deep discount as well.
Okay, because why I ask is my patient, because I'm a renal nurse, solely rely on iron sucrose and erythropoietin. And if this your method will be very good for them, I would like to experiment to see how they can you can use it to build up their hemoglobin.
Absolutely. So I'll make sure to follow up with you on an answer as far as how to get it to patients.
All right. Thank you.
My pleasure.
What's the elemental iron in one capsule? Is it a capsule or a tablet?
It's a capsule and it's 30 milligrams of ferric pyrophosphate. And then it's a white powder, as I mentioned. It can be opened and put in any type of feeding tube. It could be mixed with yogurt or applesauce if a patient is averse to capsules as well. And then I do see here on the right, so Brenda is asking where in the GI tract is the iron absorbed. So it's all throughout the small intestine, so the duodenum, the jejunum as well. So the benefit of that is if a patient has bariatric surgery, we're still effective in increasing the hemoglobin because of that jejunum absorption as well. And then the Felix is asking the cost of sucrose. I don't know the official answer to that. I have heard 300, but I'm not sure on an exact answer.
Some more questions, Sam. If there's any effort to address a fake, falsified, and substandard medicine, particularly in the low and middle income countries? Someone is asking. That's
an excellent question. I don't know if I have an answer for that one, but it's a very interesting question.
There is another oral tablet that has a similar name. It's called, is it Sucrofer? Did you heard of it? I mean, there are other iron that sounds the same. Mandy, Sucrofer. But it's not. I don't think it is sucrosomal, but it's similar name.
So there are a
because
few, Abigail, there are a few liposomal iron forms. If you looked at that gastric resistance study, you could see that even the liposomal iron is partially broken down in the upper GI. And then the gastric bleeding study I showed had a liposomal form as well. So that additional layer of the sucrose esters is what really shields it and protects it. So it's more gastric resistant in the upper GI and has more bioavailability and a higher absorption as well.
Is it available in Asia? In Malaysia or in
I'll have to double check on Malaysia. I know we're available, I believe in China, and then I'll double check on Malaysia.
Cute.
I'll check on Nigeria and Malaysia as well.
Yep.
And I think Sandra Mann
Thank
has
you
a question.
Yeah.
I see her hand is raised. Sandra, do you have a question?
Yeah, actually, just a couple thoughts. So Sam, what has your response or reception been in the US to like with the hospital setting or the clinic settings?
Sure. So hospital setting has been positive, especially in lieu of certain inventory issues with standard of care with various IVs. To have an alternative that's going to limit the constipation. Clinicians have been excited and pleased that it doesn't have that high incidence of constipation, dark stool. So the compliance is a lot higher. And just having an option for patients who would prefer an oral form over an IV that has a similar outcome in terms of the increase in hemoglobin. So we're working with a few PBM and bloodless programs throughout the country. And then we also work with private practice as well, OB, gastroenterology as well. And I've had great feedback with a few oncology patients that had a similar increase in hemoglobin to IV without the need for the IV.
Which actually brought me to my next question. Thank you for that. With GI, as far as you had mentioned a little bit of a few of the conditions, but like with Crohn's and GI conditions where the absorption is really truly difficult, you're still seeing a moderate enough improvement to make a difference on patients like these without having to resort to like IV iron even?
Absolutely. Great question. So we have a number of studies in various GI conditions, IBD, celiac disease as well, where typically oral iron is ineffective. In fact, the one study, patients had already failed oral sulfate, and they saw a positive outcome with Citarol and an effective outcome even when the GI is compromised.
Thank you so much.
Of course.
Do we have any remaining questions? I think that about covers it. I don't see anything else in the chat or hands raised. Well, thank you, Sam. And thank you to all of our 4 presenters for kind of sharing your knowledge and experience from around the globe. So it's been a great program day. And I just want to highlight the talks that are on the schedule for tomorrow, May 15th. So we'll have 3 talks: palliative care and ethical requirement in oncology, pain management in oncology, and controlling gastrointestinal symptoms in cancer patients. So we hope you can continue to join the rest of the talks for the remainder of the week. And I think before we end, we would like to take a group photo. Yeah, Nathaniel is sharing the program and can reference later on. So we have a full week planned. And I think we want to take a photo before we leave for the day. Is that correct?
Yes, please, we should all turn on our cameras.
Yep, everyone can turn on their cameras for the photo. And I think that Nathaniel, are you going to put us into
Gallery view, yep.
Okay.
Let me see the spotlight. Okay, so We need to put
We
on our
done?
smarts now. And all the
Okay.
photographers in the group should go ahead and take screenshots.
Who's taking the screenshot?
All of us.
Okay.
And then we'll see who is the best photographer. Aha, Dr. Bassi is on now. So we have to take another one. Dr. Bassi is our blood banker. So it's great to see him in the Bloodless group. Abel, have you been able to take any screenshot?
I'm not sure how to take it is an issue.
Okay, I think I've taken a couple.
Okay.
All
Except
right. So over to you, Victoria and Mandy, please.
All right, so yeah, I think
Sorry, I'm sorry. I wanted to highlight and I ended up muting. Sorry.
Oh, no problem. Yeah, I think that sums up everything for today. Thank you so much for joining and have a great rest of the day.
Thank you, Victoria.
Bye.
Thank you,
Take care.
Thanks so
everyone.
much.
Bye.
Everyone did a great job. Thanks.
Goodbye.
Thank
Bye-bye.
you.
Thanks for your presentations.
Bye. Bye, Richard. Bye, David.
Everybody have a good day.